One of the things that we wanted to do in this session was start to talk about, sort of there's this new reality about screening. We're finding all these smaller nodules, and things like biopsies are getting tougher when they're tiny, and yet we can estimate probabilities of malignancy better. And so I wanted to explore this, how we think about what we might do with these cases that are a little bit more challenging. First off, I wanted to ask the surgeons, does this resonate with you at all, the idea of when you look at a nodule and you either do growth assessments or the risk calculators, do you think of it that way where you say, hey, this one has a really high probability, I can go straight to surgery? Does that ever occur for you to just sort of say, let's just go right in and operate? Dr. Altorki, since you're the senior surgeon on this.
So, generally speaking, I'm old-fashioned, and I like to see a biopsy first. It is usually a discussion with the patient. And some patients actually want definitive proof of cancer before you take them to the operating room. Others can't abide the idea of surveillance with a spot in their lung, or they just want it out, or their friend had lung cancer and died from it. My personal preference is if I'm going to do a major intrathoracic procedure of some kind, I would like to be reassured that I'm not going to have a patient return with a granulomatous disease and, then maybe perhaps have a serious complication, bleeding, take back. I mean, there's all sorts of things that you can consider that I don't think are accounted for in the prediction models.
I think that Dr. Hakami said it perfectly. It depends on the patient. And, the patient usually will do whatever we recommend as physicians. They're not just coming to you for surgery, they're coming to you for your opinion. And you got to be careful as a doctor quoting probabilities. I got a master's in biostatistics. Probabilities are for patient populations. What you have in front of you is a patient, an individual. So you talk about it. This is actually where you have to have a real relationship with your patient, and you go over the risks, the benefits, and then ultimately you come to a decision. What I find when I'm talking to my patients, I describe nodules as two types of nodules. There are turtles, which are just little things sitting there that could be carcinoma in situ, et cetera. They're not going to kill you. They're sitting there and they can grow really slowly. And they are rabbits, where this is going to grow quickly and it's going to jump around and it'll kill you quickly. And I usually can reassure them this is not a rabbit. This is either benign or it's a turtle. And I think that gives them a little comfort to know that you can have a cancer in there or a carcinoma in situ, but it's not killing you. And that's, in the end, you got to go back to why was that patient, why did that patient have a CAT scan? Were they screened because they're high risk? Were in the emergency room because they had abdominal pain and you see a little nodule there? You have to get to know your patient to help them make the best decision possible.
You guys want to add anything to this?
Yeah, go ahead.
Yeah, I personally never do surgery before I have a diagnosis unless I have emptied all the possibilities for a preoperative diagnostic, such as CT-guided biopsy or bronchoscopy. And I can't tell you why, because it happens. What happens, usually it happened to me many years ago. I was forced to do a resection, and from the pulmonologist, this is malignant, this is malignant. I go in there, PA injury, patient almost bleeds out, and we found out it's TB. So after that, nothing without biopsy.
Scar.
Well, a lot of depends on who you have on the other side. I mean, the radiologist, pulmonologist. Because if you have a good, skilled people who have high accuracy of doing biopsies or bronchonavigation or anything, then you probably would have the diagnosis. We in Gdańsk, we have the strategy where more than 90% of people have diagnosis before we go on with operation. This is mainly thanks to David, who came once to Gdańsk with Claudia, that was 2011, and he had a presentation on the biopsy, and the title or undertitle was that there is no tumor that is not available for biopsy. And Gosia Jelito, who became later a radiologist, she was a student, he take a dip into her heart, and she's really, really very accurate, and her accuracy is over 90%. So we're sending almost all the patients for biopsy, actually.
Yeah, right now, the American College of Chest Physicians and the British Thoracic Society, in their guidelines, they state that if a nodule is greater than 8 millimeters and if the nodule malignancy risk based on models is greater than 65%, that you can go straight to surgery. That said, I don't think I know of a single surgeon who uses the nodule malignancy prediction risks. I think they go by their own clinical judgment together with the patient. And I agree with all the speakers here that I think it's very important to try to get a biopsy if you can before going to surgery, because basically the reputation of lung cancer screening programs is in part based off of the benign resection rate. People who want to diminish and cause doubt about lung cancer screening programs, they're going to go straight to that benign resection rate. So we have to get that as low as possible. And the best way to do that is get a biopsy before surgery.
Dr. Altorki is going to add.
Yeah, I think the problem really, David, is not the surgeons, but the radiologists. So, you know, many times you get these radiology reports that say this lesion is on the adenocarcinoma spectrum, which is, it becomes impossible to defend. And the patient now has heard the C word or the T word. They don't care. As soon as you say this is a slow growing cancer, they don't hear the slow growing part. They hear cancer. And that pushes everybody in the direction of the operating room, which in the case of subsolid nodules may not be necessary for their lifetime. And I wish radiologists would move away from this adenocarcinoma spectrum that appears in the impression. And now everybody reads the report on their phone and they are in total panic because of that.
That, by the way, was one of the main topics of discussion at the last I-ELCAP meeting that we had. Is it on? Yeah. Marianne is she's really just cheerleading for me. We had exactly this point, and apparently there are certain rules now where you must report these kind of things. What was the it was passed by, it was literally a congressional rule about you can't keep anything from the patient, that kind of thing. So if
well, you're not keeping anything if you don't know.
If you have a growing non-solid, you're not supposed to just say, you're supposed to say what you think it is, and you literally it's like required. This came up in one of the last meetings. Unfortunately, Molshon isn't here now, but he actually showed me the article, and then Ella was talking about it's being discussed in all the radiology circles that you're supposed to say this now. But let me move away from that for a moment, because I wanted to get to what Jeff said. You know, that there's certain guidelines, and 35%, and whether it's 35% or 20%, it kind of translates also into, well, if you can say that this nodule has over 80% chance of being malignant, therefore you're justified in going straight to surgery. You don't need to do anything else. That's how I would translate that. If you're allowed a 20% or 30% benign rate, then if I have an accurate nodule risk predictor that says this is, you know, 75 or 80% chance of being malignant, you'd be fine in going to surgery, because then you'd still wind up with that same kind of rate. But let me make, I want to show a few cases, because I want to sort of stress test the surgeon's views on how they look at this. This is, this, by the way, just gives you an idea that as tumors, we all know as tumors grow, your chance of curing them starts to go down. And in all essence, you can call this the YIP rule. This is from Rowena made this, but every millimeter the tumor grows, your chance of curing that person goes down by 1%, a little bit more. So if you start at 5 millimeters and you wait till it gets to 6 millimeters, your chance of curing it goes down from like 95% to 94%. So every millimeter you lose that chance. And so if you wait a year, you grow 5 or 6 millimeters or more, your chance of being cured goes down 5%, 8%, whatever. So that's sort of in the back of our heads. Whenever you do the watchful waiting, if you lost nothing by waiting, then you always should wait, right? I mean, if it grew and it didn't change your probability of being cured, then you would always wait. So there's no question that. So let's just look at a few cases for fun. Here's a case, and you can see on the left side it's less than 2 millimeters, and nobody's going to do anything there. And then a year later, it's it's 3 millimeters. A year later, it's 4 millimeters. A year later, it's now over 5 millimeters, right? Now, and it's growing at a typical malignant rate. Now, this is a little bit on the slower side, but let's say it was growing a little faster. Point is, I can give you an estimate of what I think the chance of this being malignant is, and it's very high. It's consistently growing at a malignant rate, very high. This is not an easy biopsy, and maybe some places have people that can biopsy this, but largely these are pretty tough biopsies, and there are also complications. So the question is, what do you do with this patient? Now I give you a probability of malignancy, and it's deep, right? This is not going to be a wedge. This is going to be a lobectomy. So how much does that weigh in your mind? Would you be willing to say, listen, there's nothing we can do. We'll try to biopsy. The chance of it being positive on a biopsy, maybe somebody will get it, but there's a good chance they won't get a pneumothorax. You know the whole song. So now I tell you, hey, but this chance of being malignant is over 90%. How do you think about these cases? Does that matter to you? When I say we can give you a probability prediction, do you just want, how do you go about thinking about these cases? Jeff, why don't you start at that end?
Well, so for me, when I see this case, I see the airway right next to it. So I would try to do a robotic navigational bronchoscopy to try to get it. And I guess to just make it a little bit more challenging and put myself on the spot, let's say the bronchoscopy is non-diagnostic. Then what do you do? And I think at that point, you have to have a conversation with the patient, but probably I would try to, I'd probably try to take it out. Well, I think this would probably, I mean, I think you'd probably have to do a anatomic lung resection. I mean, yeah, like a lobectomy. Yeah, you have to do a lobectomy for this.
Less than a lobectomy.
Yeah.
And you talk about every millimeter reduction in survival and all that. You have to balance that against what is the immediate risk of surgery. In the CLGB trial, which was done across 80 institutions in Canada and North America, only the best centers, I would say, the mortality, the 30-day mortality of lobar resection was 1.1%. So it is not nothing. I mean, yes, there is a 1% chance of reduction in survival, but there is a 1% chance that you will die before you leave the hospital. So that's what we weigh. And, I appreciate all the 0% mortality, but if you do a lobar resection, I don't care where it's done, there will be some finite 30-day mortality associated with it. And the other thing about these things is that, if this was a peripheral lesion,
It's the next case.
so might as well just discuss that, because the calculation of risk changes, because you can robotically, bronchoscopically mark the lesion, even if it's not immediately subpleural, and do a wedge resection, and that changes the equation.
The other thing to think about when I look at a case like this, I see it, that's a left upper lobectomy. For the non-surgeons in the room, left upper lobectomy is probably the most dangerous lobectomy. There's this artery that comes off very close to the heart that can tear. I see this patient looks obese too. That also increases your risk. It's not just the surgery. And I'll give you an example. We had a patient several years ago. We took the patient to the OR. You have to isolate the lung. They put in something called a double lumen tube, the anesthesiologist. Next thing you know, a bunch of blood comes pouring out. It ended up, they tore the back part of the trachea and shoved it into the inferior pulmonary vein. So a ton of blood is pouring out of this. First of all, we put chest tube, couldn't get an airway, trach the patient, flip the patient, big thoracotomy / grab the airways, sew that up, wedged out the lesion that was there, benign. Now, thank God the patient recovered.
Yeah, that did not happen at Sinai, probably at MSK.
That actually happened at MSK. It happened in 2008. The patient walked out 5 days later. So thank God they were fine. But it's not just the surgery. Let's say they got antibiotics. Next thing you know, they had an allergic reaction. So there's nothing benign in medicine. And if you should go to the OR only when you're sure, or at least 99.9% sure that this is a cancer. So if I see something like this is screaming cancer to me. I would take that patient. But, you know, back in 2022, is that risk of some other complication worth the small benefit in survival? And that's what you're constantly weighing as a doctor, the risk benefit. And it depends on that particular patient.
See, I'm trying to sort of see if we can put, if we can put numbers on this, how meaningful that would be with you guys. And to an extent, I'm hearing not really. You're balancing the occasional case that something really screws up, that colors your decision dramatically. So these are the kind of things that I'm trying to kind of get my arms around, because I can tell you a probability here, but that's not going to do it for you.
The probability is that in 2022, this patient had 100% probability of survival at 3 years.
Yeah, that's for sure.
And then I don't want to open up a can of worms yet. We'll talk about it next. But then does radiation come into play here? And is there a downside to doing radiation when it's a little dot?
Let's look at another case, and probably this will be the last one we'll do. So I wanted to show you the same sort of thing. This one, I think is more in the wedgeable session, for the surgeons, right? But again, you see the same thing. It starts as tiny, then it grew. And I've had patients in the screening program come to me, because they read their reports and they say, hey, I saw you saw this nodule grew. Should I be nervous? And I said, well, it's, 2 millimeters, 3 millimeters. Don't worry about it. Come back in a year. And now it's grown from 2 millimeters or 3 millimeters to nearly 5 millimeters, whatever. You get the picture. That people get nervous when you say, hey, I got something in my lungs that's growing. Now, again, this is the kind of case where, biopsy could be done. Not every place has people that are going to be willing to biopsy this kind of lesion. And the biopsy can come back negative. But if I can give you a probability on this, let's say that I say to you that we now have our super duper risk calculator, and it does radiomics and artificial intelligence and whatever else. And I can say, hey, the chance that this is now malignant is 99%. Right? And all it's going to require is a wedge. You go straight to surgery?
I'll start again. So for me personally, I would still do a biopsy of this, and I'd do at Mass General, we do a lot of CT guided biopsy with fiducials, so that it also makes it easier to do a wedge resection. So, but I hear your point, David. If it's 99%, do you need the biopsy? I think that probably it seems from what people have been talking about, we've all had experiences of doing a benign resection, and it feels very, it's a challenging situation when that happens. And so anything to minimize that, even if it's projected to be a high risk to be lung cancer. For me personally, I would do a biopsy with a fiducial.
How you can tell me that this is 99% probability that this is a cancer? I don't think so that you can do that because, you know, the probability relies on statistics and it doesn't take into consideration the patient's characteristics, which also has influence. And then another thing is how you present it to the patient, because finally you will discuss with the patient that you have a tumor, which is maybe cancer, and what to do. If you tell him that this is 99% of probability, he will probably go straight. He will press you to go to surgery. I never use percentage. I'm just saying that it can be cancer. The probability is pretty high. What we do. So
isn't what we do in medicine now all about trying to get this kind of precision? I mean, I think this is the way we're trying to head. At least these are the numbers that we're trying to generate. And
So let me ask you
everybody
something.
has a risk predictor now. If you look at all of the new software that's coming out, you look at the Siemens software, every nodule that it finds automatically, it tells you its probability of malignancy. Now, I'm not saying how good it is or bad it is. I'm not trying to do that, but this is really coming. And now when you incorporate things like its doubling time and growth rate, which is probably the best predictor, our ability to predict is just getting better and better. And so I'm trying to get the thoughts about how much that influences your thinking. And it's very clear that it has some impact, but clearly there are other factors. And of course, you know, the patient's preferences and all that. But all the surgeons, it seems to me, are colored more, or at least to a large extent, not so much by that probability, but by the impact of getting it wrong, you know, and doing something benign, operating on a benign, especially a lobectomy, is something you want to avoid at almost any cost. This one I put up in particular because it's peripheral. And, you know, Raja is always telling me, you know, 3 little holes, he's out playing golf tomorrow, you know. So, you know, why should we...
David, in your hands, in your hands, what is the risk of this biopsy and what is the positive predictive value? How many times can you get it? And negative predictive value and what, yeah.
You know, truthfully,
And what is the risk?
The risk of pneumothorax in this is, you know, whatever, 10%, being, you know, chest tube, 5%, something like that.
Risk of death?
Chance of death,
Yeah,
is virtually 0. I mean, I've had personally, I think two deaths out of about 15,000 biopsies.
okay.
I've had 2 deaths. But you know, even with this, there's a chance of hemoptysis, sure, you know, small percentage, but you know, these are relatively good lungs.
What's the negative predictive value?
Very high. I don't have the exact number for that, to be honest. But it also, to an extent, depends on how well the procedure went. I can kind of tell you that after the fact, if I know that the needle was really in the lesion, that sort of thing.
Yeah.
My chance of getting an answer on this, for me at least, would be around 90%.
Yeah, so I think it's, you know, models and all that are great and they sort of provide general guidelines, but ultimately we weigh this on an individual patient basis and what their individual risk is, and patients are different in their comorbidities, in their, you know, in multiple ways. So, and I do think that the robotic bronchoscopic biopsies approach are amazing. I've been very impressed, and they're not 100%, they're foolproof, but they're really important.
Yeah, I think you can't just look at it in a vacuum. You can't just look at a scan and say, what's the probability? And should we biopsy it or should we take it out? You know, does this patient have bad coronary artery disease, you know, critical aortic stenosis, stuff like that? You know, in those cases, you know, you may want to be sure you have a cancer before putting that patient under anesthesia. Then you say, well, it's 99.9% sure that you have a cancer. And then you're balancing, is this going to kill the patient, or is their coronary artery disease going to get to them first? You just can't separate the patient from the anatomical thing that you're looking at.
So the surgeons are arguing towards,
But the final question is, what would each of us do in this case?
well, what I was really trying to put, I'll ask that question in a moment. But what I'm really trying to say is, if we get to the point, and I think we will get to the point where I can say this is 99% sure, or whatever probability of malignancy. And it may not be this case, but with the quality of the scanners and our ability to measure doubling times and nodule features, we're really going to be able to predict. That prediction rule is getting better and better. So I'm trying to say, we can think about that now. Let's say we can predict. Let's say I can say, hey, this is 96.7% probability of malignancy. At that point, do you say, well, that 2 or 3%, I still want to do a bronchoscopy or some other procedure before going straight to surgery? And it sounds like there's a lot of hesitation thinking that way. You guys want to think a little bit differently. And you're weighing, and the other factors seem to weigh more than these kind of probabilities. That's sort of what I'm hearing when I listen, which is a really interesting way of thinking about things. So let's take your question, Jeff. What would the surgeons do here? This is a 95% chance of being malignant. Jeff, what would you do?
I'd probably still do the biopsy and then have a fiducial and make it easier to find it in the operating room.
I think the question was resection. What kind of resection do you do? Is it correct?
Wait, what kind of
No,
resection?
what would you do? I'm saying,
Yeah,
here's
yeah,
the
so-
patient we presented to you. I've given you this probability of malignancy. It's been growing at a malignant rate for the past 4 years, 5 years. We really are very strongly sure that it's malignant. This would be a chip shot, as they say, for a wedge. Easy wedge for you guys. Why wouldn't you just go and wedge it out instead of, well, I'll try a robotic bronchoscopy, which has they don't even know what their probability of getting something like this is. There's no bronchus nearby. For me, whatever, I told you my chance of
Yeah,
getting.
I think that for this particular wedge, for me, it wouldn't be a chip shot to find. So I would do a biopsy with a fiducial to make it easier to localize. But I guess, David, to your point, let's say this
I'm
was
trying to get to the point where it is a chip shot.
exactly. Let's say it's like 1.8 centimeters. It's right on the periphery, and a risk prediction model does say it's 96% likely. I think that in that scenario, which I probably would just go ahead and take it out then, assuming that the patient is healthy and things like that. Probably where my hesitation comes from is I haven't seen a model nearly that good, but I think in that scenario, I'd probably go straight to surgery. A wedge. Yeah, do a wedge.
I'm setting this up to be the wedge. This is an easy wedge for you. We're not worried the patient's healthy. He's, everything else is all set up that a wedge should be really successful. Witold, what would you do?
This is not
Does this matter to
necessarily
you, or do you still?
this is not necessarily easy wedge. You know that after you get in, if it's easy or not. It could be problematic also. But fine. All in all, I would go to. I would propose patient if he's fit. Propose him operation.
You do a thoracotomy?
No, I would do VATS, of course, because you can't do it. Probably you can't do it with robotic. I mean, would be very difficult. You have to palpate it first.
Ardashir, what would you do? Is there a probability that you say, okay, maybe it's not 90, maybe you want to hear 98%. And then, we can play around with how low do we go before you say, well, I really don't want. And that's where I'm sort of trying to get. But in this case, I'm giving you, it's really high.
This is not an easy case. I think at the end it comes to a discussion with patient, the risk factors, as you say, if patient is healthy, all those together.
Healthy.
Yeah, patient is healthy. It's if you want to do it's a wedge resection, but I would rather have a diagnosis before I make because surgery causes patient unnecessary pain, sensitivity problems. It's not without any, it's now cheap coming to patient with surgery. It's minimal invasive, but still patient 3 months after surgery, they have problem with. So if we can avoid it, and then I look at the patient, in which age category is this patient gonna, of other reason, die within 5 years, or the complication may hurt him or her.
Dr. Cortez.
So I know what you're getting at. Yeah, I'd go in there and just wedge it out, but it would depend on this conversation with the patients. If I went in there, I would probably tell the patient, why not just biopsy it? If it comes back as granuloma, then we don't have to operate. And then they say, doc, I just want it out. Okay, we'll take it out. You'll go home, in a day or two. That's basically the conversation. It really depends on the patient. Now, the situation to think about is sometimes you get in there and someone has lumpy, bumpy lungs. And, is this the lesion? You're digitally palpating it. Is this the lesion? If you have a biopsy that shows a cancer, then you take that out and you confirm it pathologically. Because if you just go in there like this and you think you have the lesion, you take it out, you go to path and it says benign, then you say, okay, it was a benign lesion. So there are other little subtleties that in surgery you may run into.
And you send it to path and they can't find it.
That happens. That happens. And that's why there's so many.
So what do you do when that happens?
Well, it depends what. This thing,
Uh,
you would know you have it.
okay.
So then if they didn't find it, you wait for the final. You don't keep chopping out lung and doing all kinds of other
Then take the
things.
patient back?
This you'll get.
Okay.
You're going to get this.
Dr. Altorki, do you have
I won't picture you.
Dr. Altorki, do you have a final word to say?
I think it's a problem. I think that's why I'm telling you, I'm very impressed with the ability of the interventional guys to come to the operating room and do a bronchoscopic marking, whether it's methylene blue or the ICG, because at least you know what neighborhood that lesion lives in.
But it can miss mark
And
and it can travel. Let's say you put a fiducial, it can go somewhere else.
I haven't seen that very much.
I have.
Okay, well, then you need somebody else to do it for you.
Well, I've got to say, in the thousands of cases, I've never had to use a fiducial or something. If it's that subtle, you probably should not be taking that patient to the OR. So I think you got to wait to a point where you can easily palpate.
So you
it and
managed
get
to
there.
drive a wedge between the surgeons now.
So no, I want to, that's not difficult, but we're going to close this session, but I think what it really points out, it's just sort of the difference between science and art. And what the surgeons do is really, to a large extent, art. It's hard to put numbers on things. It's really hard to put, say, here's a probability. This is therefore, this is the algorithm. This is what you should do, because there's always another level of complexity that they're trying to weigh, and they're weighing it based on a relationship with a patient. So, I recognize these are really tough decisions. I was sort of trying to push the envelope a little bit, but when the patient's in front of you and you're having to tell them that we're going to chop something out of your lung and that's not an easy thing to do. And you have to bring in your own experience of that one patient that you took something out and he nearly died on the operating table. Even though it's a 0.5%, that carries a lot of weight in your decisions when you're talking to another patient. So I get that, but I think we accomplished what we wanted to bring out some of these issues as to how you think about things and how you have to weigh and balance these. So thank you very much. That was a wonderful discussion.
Wait, sorry, I just have one more question. What sort of technological advancements would you make you confident to go into surgery without a biopsy?
Technology?
None.